Thank you very much, Professor Muhammad Al-Mahdi, for the nice presentation and the wonderful moderation of today's webinar. And definitely, I would like to thank Professor Hassan Ali, my professor, my mentor, and he taught me everything in infertility and in more than just infertility. And I would like to thank IFRI for their scientific work and for the choice of the day regarding the live birth rate, because it is very important that we know that the final aim of our patient is to have a take-home baby, not just most of clinicians regarding the success is the clinical pregnancy rate, but for the patients, the live birth rate or the take-home baby, this is most important. We'll talk about how to improve live birth rate in PCOS patients. According to the WHO, PCOS is the most common cause of anovulatory infertility. Women with PCOS are typically more difficult to stimulate in a controlled manner, whether you are intentionally want to induce a monofollicular or a multifollicular response. They are more likely to demonstrate resistance to stimulation, and this is maybe unexpected, but some PCOS patients are very resistant to stimulation or maybe exaggerated response, so they may have a high cycle cancellation rate in addition to the inherent risk of ovarian hyperstimulation syndrome. Of course, as we mentioned in the last webinar, that most people diagnose PCOS by the Rotterdam criteria, the well-known criteria to diagnose PCOS after having 2 out of 3 hyperandrogenism, either clinical or biochemical, menstrual irregularity, and polycystic ovarian morphology. Now we'll start about what are the variables and the predictors of pregnancy in PCOS patients. And first we'll talk about age, which is one of the most important indicators of success in our cases. It was found that in PCOS patients, there is a slower age-related decline in treatment outcomes after their first IVF cycles, which means that in this study on more than 3,500 PCOS patients, and they compared them to more than 18,000 patients with tubal infertility, and the main outcome was the cumulative live birth rate. It was found that in PCOS patients above 40 as compared to non-PCOS patients, the implantation rate in these older females is higher, the clinical pregnancy rate is higher, live birth rate is more than double that of non-PCOS patients, and the cumulative live birth rate is also more than double. We are talking about 50% cumulative live birth rate in patients above 40. These rates were comparable among PCOS patients which are even between 35 and 40 years old. So the changes in the implantation rate, clinical pregnancy rate, cumulative live birth rate were slower for PCOS patients than non-PCOS patients. Among PCOS patients less than 35, BMI significantly decreased the cumulative live birth rate. However, among older patients older than 35 years, BMI was not an important variable, but the number of retrieved oocytes was significantly associated with cumulative live birth rate. So they concluded that the decline in treatment outcomes with age is slower for PCOS patients as compared to non-PCOS patients. For patients over 40, PCOS have a reproductive advantage over non-PCOS patients. So when you have an older PCOS patient, please inform this patient that being a polycystic ovarian syndrome patient, this is something good at age above 40, and she's happy of this diagnosis because her pregnancy rate is better than that of the non-PCOS patients. Also, in younger PCOS patients, you need to decrease the BMI before starting your cycle in younger patients. While in patients above 35 years, PCOS patients, you don't have time to decrease their BMI. Also, decreasing the BMI in this subgroup of patients, those above 35 years old, does not increase your live birth rate. Now, regarding AMH, and this is an astonishing study that just published this year, found that in cases with very high serum AMH PCOS patients, the pregnancy rate decreases. They categorized the PCOS patients according to the percentile to those with AMH below 3.3 and those with average AMH between 3.3 and 8.2, and with those with very high AMH above 8.2, they found that low serum AMH women had significantly greater live birth rate odds as compared to those with average and high AMH. So here the AMH is a negative predictor value. High AMH, this is a bad predictor for pregnancy and for live birth rate in these patients. Even after adjusting for confounders, AMH, extremely high levels of AMH is a bad prognostic factor. Lines of management of PCOS include lifestyle changes, oral agents, gonadotrophin stimulation, laparoscopic ovarian clearing, and IVF or ICSI. First, we'll start with lifestyle changes. In a very recent study that will be published next month, they found that high BMI and high total serum cholesterol were significantly associated with lower live birth rate in PCOS patients. And delaying fertility management to improve the lifestyle is better, especially in cases stimulated by clomiphene citrate. And this study included lifestyle modifications, including caloric restriction, anti-obesity medications, behavioral modifications, and exercise. And data indicated that improved ovulation rates and live birth rates when patients were delayed the fertility management till improving their lifestyle. And so it's better to wait before immediate start of oral agents. BMI and the effect of BMI, there is also a question, does it affect the oocyte quality or the endometrium or the perinatal outcome? So to answer this question, there are studies that examined the effect of BMI in freeze-all cycles. First, this study that was done on more than 3,000 PCOS women, and all were for freeze-all strategy. The live birth rate was most favorable in the underweight and the normal weight cohorts, and progressive decrease in BMI had a worse outcome. So obese cohort has even a high early miscarriage rate. So even in frozen cycle, lower BMI is better, and high BMI will lead to lower pregnancy rate, high miscarriage rate, and low live birth rate. However, another study that was published also in 2019 found no effect in frozen cycle for the BMI. So in frozen cycle, it is still debatable, but in fresh cycle, it's better to improve your BMI before starting your cycle. So according to the guidelines, pharmacological anti-obesity patients should be considered an experimental therapy in women with PCOS for the purpose of improving fertility. Also, bariatric surgery, as we all know, this is very common nowadays, but in the context of improving live birth rate, bariatric surgery is an experimental surgery. Okay, in morbid obese PCOS patients, bariatric surgery may improve a lot of things, but it can't be done only to improve live birth rate. Regarding oral agents, we'll start talking about insulin sensitizers, especially metformin, and in a Cochrane database in 2017, metformin alone found to be beneficial to increase live birth rate. So this may be a solution for patients who can't come for follow-up or traveling away. Even prescribing metformin without any other oral ovulation induction agent increases live birth rate as compared to placebo. So metformin could be used alone in women with PCOS with an ovulatory infertility and no other cause to improve ovulation, to improve pregnancy, and to improve live birth rate. Although women should be informed that there are more effective ovulation induction agents. So enough metformin alone is okay, but you should inform your patient that it's better even to take metformin in addition to clomiphene citrate or in addition to letrozole. Cochrane 2017 found low quality evidence that adding metformin to gonadotrophins increases the live birth rate. So according to evidence, metformin alone is effective, metformin with oral agent is effective, metformin with gonadotrophins, all of this will increase your live birth rate. Metformin, even there is some studies that metformin in IVF or IVG cycles, there is no conclusive evidence that it improves live birth rate, but there is an evidence that it decreases the risk of ovarian hyperstimulation and increases the risk of the incidence of clinical pregnancy rate. So giving metformin during stimulation for the IVF cycle, according to the Cochrane, it doesn't increase the live birth rate, but it increases the clinical pregnancy rate, and it definitely decreases your ovarian hyperstimulation syndrome. So the bottom line is you should give metformin to all cases. Metformin alone, metformin with oral agent, metformin with gonadotrophins, metformin in IVF exit cycle. If you are going to compare letrozole to clomiphene citrate, according to the evidence, there are 13 randomized controlled trials comparing letrozole to clomiphene citrate, and it was found that letrozole has a better pregnancy rates and live birth rate, and that's why letrozole now moved to be the first line pharmacological agent instead of clomiphene citrate. What about gonadotrophins? According to evidence, gonadotrophins were available and affordable, should be used in preference to clomiphene citrate combined with metformin for ovulation induction. So, gonadotrophins gives higher live birth rate when compared to oral agents. But definitely, you should know the price, the safety profile, the increased risk of ovarian hyperstimulation syndrome. In addition to, you should follow up these patients. Oral agents can be given even without follow-up. So if you have the facility for follow-up, no problem regarding the cost, and you are very cautious regarding hyperstimulation syndrome, gonadotrophins offers higher live birth rate than the oral agents. In addition, as we mentioned before, it is better to add metformin to gonadotrophins, not only as aiming at decreasing hyperstimulation syndrome, but also aiming at increasing your ovulation rate, pregnancy rate, and live birth rate. What about ART? ART represents the third line of management of PCO patients. While a high number of oocytes is usually obtained during ART, there are concerns that quality and the maturity of these oocytes may be compromised. Despite this, live birth rates after ART in women with PCOS seem to be comparable to those of women with other diagnoses. So, you will have more oocytes. Maybe you will have a lower quality. Maybe you will have a problem in oocyte maturity. But the high number of oocytes will counteract this bad effect. So at the end, the live birth rate in PCOS after ART is comparable to tubal factor, is comparable to unexplained infertility, is comparable to mild male factor infertility. When you are doing ART, give agonist or antagonist. The Lambert study, the meta-analysis, the very elegant study that categorized the patients to low responders, intermediate responders, and high responders, found that agonist and antagonist have comparable pregnancy rate and live birth rate in PCOS patients. However, there is a marked reduction in hyperstimulation syndrome, relative risk of 0.5 after using the antagonist protocol. So here we are using antagonists not to maximize the live birth rate, but to minimize the ovarian hyperstimulation syndrome. And you are doing this without decreasing your live birth rate. We mentioned in a couple of webinars the different phenotypes of IVF, of PCOS. And there are 4 phenotypes of PCOS according to the presence and absence of different criteria of the Rotterdam classification. So if you have all 3 criteria, this is category A. If you have oligo or anovulation plus hyperandrogenism, this is category B. If you have hyperandrogenism and polycystic ovarian morphology, this is C. And if you have oligoovulation plus PCOM without hyperandrogenism, this is category D. As it's noticed here, Hyperandrogenism is present in the first three categories. This study compared the different outcomes of IVF according to the classification of patients according to different phenotypes, and they found that live birth rate after fresh transfer of all fresh and of vitrified embryos, so we are talking about cumulative live birth rate, were lowest in the subgroups with hyperandrogenic PCO, which are phenotype A, B, and C. So as compared, all patients with hyperandrogenism, which are subgroups A, B, and C, have lower live birth rate as compared to subgroup C. This meta-analysis, they looked at different factors that affect the outcome of ART in these patients. They found 41 studies comparing PCOS patients, and they found a low to moderate quality evidence that antagonist protocol is preferred, and as we said, not to increase live birth rate, but to decrease OHSS. They also found a low quality evidence from 10 studies that metformin has a positive effect on live births and ongoing pregnancy rate. This conclusion contradicts the Cochrane that said that metformin only decreases hyperstimulation without increasing the live birth rate, but they, in these studies that included 41 studies, this meta-analysis found a positive effect of metformin on pregnancy rate in cases prepared for ART. Now, our take-home messages: the decline in treatment outcomes with age is slower for PCOS patients as compared to non-PCOS patients. High AMH is a negative predictor for live birth rate in PCOS patients. Lifestyle modifications improve live birth in patients stimulated by oral agents. Bariatric surgery for the sole indication of increasing live birth rate is considered experimental and it's not approved by guidelines. Metformin could be used alone or with oral agents. It can be also used with Gonadotrophins for cases prepared for time intercourse or IOI. In IVF exit cycles, metformin doesn't increase live birth rate but decreases ovarian hyperstimulation. This conclusion is according to the Cochrane, not according to the meta-analysis. Letrozole should be used as the first-line oral agent as it offers higher live birth rate compared to clomiphene. Gonadotrophins result in higher live birth rate than oral agents, but cost and safety should be taken into consideration. GnRH antagonist and the agonist protocols have comparable live birth rate, but the antagonist is preferred for safety considerations. Thank you very much.
Thank you, Dr. Sherif, for nice presentation. I have two questions before starting the voting. First question is, you have two cases of polycystic ovary. The first body mass index is 22 and the second is 35. AMH is 8. What is the starting dose for both cases? You start antagonist protocol. So what is the appropriate dose you start with?
Okay. First of all, cases with very high AMH, according to some observations, sometimes they need not only to be stimulated by the FSH, but I prefer to add HMG even in low dose for these cases. This is number one. Definitely, the obese patient will need a higher dose. The obese patient, I may start with 2.5 ampoules, maybe 150 plus half ampoule of HMG, or maybe 3 amps at the beginning with very close monitoring. The slim patient, probably I will start with 150 and will be just FSH. And these cases I prefer to see after 5 days of stimulation, and then I can titrate. Besides, I should always depend not just on the AMH, but also on the intrafollicular count, and I will try to take a very accurate history if she has been stimulated before, either for ART or just stimulation for timed intercourse. Definitely she will be stimulated before for timed intercourse. and I will try to see what happened before. It will give me a lesson regarding this dose.
In those. In the first visit after 5 days, you see the ovary, it was resting ovaries. There is no apparent follicles that are growing. Will you increase the dose or you wait for another 2 days?
Okay, definitely. Definitely, I will wait. In PCOS patient, don't hurry. Take your time. It's not your time, it's her time. Sometimes these ovaries will need more time. Don't increase the dose early, please. Wait for another 2 days. Definitely will be guided by the estradiol level, but definitely I'm not going to increase after 5 days. Maybe
wait
after
another
7 days, and maybe you may not need to increase. Maybe you just need to add more HMG. Maybe you don't, maybe instead of 150 of FSH, maybe you just need to give 75 units of FSH and another 75 units of HMG. Maybe this will be your solution.
Last question, does it differ the level of LH during the start of your cycle or not?
I myself, I don't measure LH before starting. I know some people are doing that, but I am not measuring LH before starting, because giving HMG in my practice, in my humble practice, it doesn't depend on the LH level. I give HMG according to the AMH level. Cases with extreme AMH levels, I give them HMG.
Dr. Hassan. Thank you, Sherif. Dr. Hassan, the first question, the starting dose for both cases, you start with a different dose or the same dose?
This is a very difficult exam, Muhammad. Not asking Dr. Hassan after asking me. This is like a trap for me.
No, 150. 150.
150.
I will
For
use the dose.
or it differ with the body mass index?
No, just 150.
150.
It doesn't make a difference.
It doesn't make difference. Yeah.
But what is very important, as Sherif alluded, and it is not stated in the guidelines, but it's spread in the literature. It's better to correct what is abnormal, because what is abnormal is what is creating the problem. If you have high androgen, you have to lower the androgen. If you have high insulin, you have to lower the insulin. BMI is very difficult to lower, because Sherif point to this, but I think that what you need in terms of BMI is just to decrease the weight 2 or 3 kilograms. And once it starts in catabolism, the responsiveness will improve. So it is 150, the starting dose, but metformin before. And if you need to use pills, you need to use pills, because Sherif actually showed, but in an indirect way, that the 3 subtypes of PCOS are all related to hyperandrogenemia, and that's what creates the problem. Okay?
Yeah.
So the starting dose is 150.
150. I ask Mr. Akram to present the voting of Dr. Sherif. We have 2 minutes for answering the questions.
Can I ask Sherif a question, Mahdi?
اتفضل يا بيه.
اتفضل دكتور حسن.
In non-exi cycle, Professor Sherif, you've mentioned gonadotrophins as a method of increasing live birth rate, right?
Yes. Yes.
What about multiple pregnancy?
Yes, definitely multiple pregnancy is more with the gonadotrophins as compared to the oral agents. And this is why I said regarding we should think about safety. And the safety is an important issue. والجونادوتروفينز وده مكتوب في الجايد لاينز الانترناشونال ايفيدنس بيز جايد لاينز 2018 ان الجونادوتروفينز offers a higher live birth rate as compared to oral agents. But safety issues are very important, and definitely the safety includes the incidence بتاع multiple gestation in addition to the hyperstimulation syndrome. Definitely safety جزء لا يتجزأ من القص.
Do you need to normalize the BMI or just decrease the weight?
لا, just decrease the weight. It's mentioned that decreasing weight from about 5%, maximum 8% is quite enough. Because if you need to normalize the BMI, usually it's very difficult, very difficult.
Yes. Are there any
نخش في bariatric surgery بقى.
Is there any difference between gonadotrophins in PCOS?
No, 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 no. All are the same. No, all are the same. According to evidence, all are the same. Okay. Now we have the result of the poll. First question. In PCOS patients, as AMH increases, live birth rate decreases. Definitely, right? Secondary question, is morbid obese patient bariatric surgery should be done? We said that it is considered experimental. So the answer is false. Only 50, almost half of the attendees got it right. According to guidelines, it is experimental. So we can recommend to do bariatric surgery just for increasing live birth rate. You may do it for any other health conditions. Third question, is metformin alone increases live birth rate if taken with other ovulation induction agents? Yes, alone it can increases the live birth rate. And the antagonist protocol, is it recommended because it increases the live birth rate? No, it's indicated because it decreases the ovarian hyperstimulation syndrome without compromising the live birth rate. So most of the answers are right, thanks to the attendee.
Thank you, Chief. We start Q&A. Plan of treatment for PCOS patient with more than with AMH more than 10. I think we answered the question. Can use metformin in non-obese patient with PCOS?
According to the guidelines, using metformin doesn't depend on the BMI, and it even doesn't depend on the HOMA test or presence or absence of insulin resistance. In the guidelines, it said that PCOS patients use metformin. Okay, I know some of us do, including myself. I prefer to do HOMA test for some patients, at least to convince them that they need to use the metformin and they need to tolerate the side effects. But according to guidelines, all patients will benefit from metformin. Either they are obese, either they are slim, either they have insulin resistance or not.
Comment about lean PCOS.
So we can use it in lean PCOS, yes.
No, another question.
Yes,
comment
please.
About lean PCOS.
This is an exam question, I think. Lean PCOS, this is a subgroup of the patients, and there are no different line of management for lean and for obese. For obese patients, you will try to convince them to lose weight, do exercise, do lifestyle modifications, and now they are talking about behavioral changes, and there is some behavioral therapy for these patients that people in the bariatric and in the diet, in the nutritional department are doing these things, but there is no separate guidelines for these patients.
Best gonadotrophin in soft protocols for PCOS.
Dr. Hassan asked this question, and according to guidelines, all gonadotrophins, either FSH urinary or recombinant, either HMG, or are equally effective. So you can use whatever you are convenient with.
Metformin dose, please, and how long?
Metformin dose and how long? Minimal dosage is from 1500, 1500, and up to 2000. How long? There is no limit for the duration. It doesn't only improve your live birth rate. Some studies said that it decreases your miscarriage rate. So you can even continue it in the first trimester. Besides, regarding the metabolic syndrome, it is proven now that metformin is prophylactic against type 2 diabetes in patients having insulin resistance. So you can give it for life for them. This is very important. Here you are protecting her from something major, type 2 diabetes, and it is proven for this indication. So you can give it for long time.
Rule of
Hassan,
other
do you have a comment?
انا هسالك برضه يا شريف. في انيمال ستاديز بتقول انه الاوف سبرينج بتاع البي سي او اس او الهايبر اندروجينيك انيمالز during pregnancy بيطلع بي سي او اس. وفي هيريديتري داتا بتقول انه التايب 2 diabetes mothers بيولدوا بي سي او اس. it is possible that this is related to the hormonal imbalance. Does it make sense that we should correct this before we start anything?
Definitely. وهو ده الدور بتاع اللي اتقال بتاع improving اللايف ستايل موديفيكيشنز قبل البدايه، لان احنا هنا بنتكلم على لان الاكسرسايز بير سي بيحسن الانسولين ريزيستنس، فهو كل اللايف ستايل موديفيكيشنز وبعدين البيهيفيرال ثيرابي هتحسن الايتنج هابتس بتاعتهم، الدايتري هابتس، فكل ده هيقاد لان هنا الامبرنتنج اللي بيحصل ديفنتلي هيبقى له دور على الهيلث اوف ذيس اوف سبرينجز.
Very good.
Rule of other insulin sensitizers acetylcysteine وكروميترون.
other insulin sensitizers مش بس اسيتايلسيستين وكروميترون، انما هو الاسيتايلسيستين اللي بيشتغل بطريقه ثانيه، وانا من الدكتور حسن اشتغل يعني كان هو مديني رساله عن الاسيتايلسيستين، الكلام ده في 2004 و2005 واتكلمنا عليه كتير. دوره دلوقتي مش كبير، انما هو طبعا له ديفينتلي دور كانتي اوكسيدنت، انما ما بقاش الافيدنس عليه بعد السنين الطويله ديت ما بقاش قوي. الكروميترون بيدوه الناس بتوع الديابيتس في حالات في الديابيتكس ما فيش ايفيدنس قوي عليه ان هو ات امبروفز الليف بيرث ريت، انما هو ديفينتلي بيحسن الانسولين ريزيستنس. ما فيش ستاديز قويه بتقول ان ده ريفلكتد على الليف بيرث ريت، واحنا عدواننا الليف بيرث ريت، فاحنا مش هنقدر نتكلم غير على الحاجات اللي احنا متاكدين ان هي هتزود لي الليف بيرث ريت. انما الكروميترون it improves the insulin resistance in these patients.
Sensitivity.
بالظبط.
في سؤال عن ال اتش انت جاوبت عليهم. Two questions on LH you have answered. Green PCOS you answered. Coenzyme Q10 role and antioxidant in PCOS.
Coenzyme Q10 الكلام عليه اكتر in poor responders. In PCOS برضو احنا we are talking about evidence, it's not present in any guidelines, so I don't recommend according to the available guidelines. The only adjuvant which is recommended is metformin. Sorry, the other question can...
Antioxidant in PCOS.
Antioxidant, the role of antioxidant in any IVF cycle is very important. مش مكتوب حاجه معينه في البي سي او اس. كان في كلام على ال كارنيتين، والال كارنيتين في كلام عليه كمان في الاوبيزيتي ان جنرال، يعني it has a beneficial effect in obese patients whatever هم بي سي او or non بي سي او، ففي كلام عليه. انما in general it is prescribed evidence based not evidence based، انما in general it is prescribed as a good practice point.
Hyperandrogenic polycystic ovary, is there is a clear strategy before starting ICSI?
دكتور حسن لسه مجاوب على السؤال دهوت and it's better to correct before starting your ICSI cycle, and according to the study that was done in 2018 that I show its result, the phenotypes with high androgen levels led to a lower live birth rate, so it's wise to correct before going into an ICSI cycle, and the simple correction is using pills or whatever anti-androgens you can be used.
There's a question from another topic. In FET cycle, day 6 embryo, after how many days of progesterone you do the embryo transfer?
Usually, we vitrify embryos on day 6 as a delayed blastocyst. So you consider it as a day 5 blastocyst. Of course, ask the lab what is the stage at which the embryo were vitrified, but usually you vitrify on day 6 a delayed blastulation. So you consider it a day 5 blastocyst, and usually the easiest way is the age of the embryo plus 1. So you consider it as day 5 blastocyst, 5 plus 1, so 6, so transfer on the 6th day. And you can transfer on the 5th day. According to evidence that we showed in our first webinar regarding FET transfer, you have, according to evidence, you have 24 hours period. You can go and for in 24 hours. So you will find some people transferring on the 5th day, and you'll find others transferring on the 6th day, and the results are comparable.
If you give HMG in PCOS patients with high LH, does this make the patient out of the LH threshold and the window as ceiling of LH is 5 international unit, leading to follicular atresia?
Very intelligent question, and Dr. Hassan have been talking about this in the last, I think, 5 or 6 months about the ceiling, maybe 1 year now. Maybe yes, I can't tell, maybe yes, but actually if you are stimulating these patients, usually you will need a low dose, usually 75 international units. So this 75, which is 1 amp, definitely you are not going to exceed this LH ceiling. Maybe you can exceed the ceiling if you are going to give 2 or 3 amps, and this is really done in PCOS patients. So I don't think that you can exceed this limit in PCOS patients, but usually it happens in the reverse, in poor responders, because in poor responders, you may have to increase the dose to 125 or even more, and this may be more than the threshold. And Dr. Hassan, if you would comment, please.
No, exactly as Professor Sherif said, with 150 unit of HMG, you will not have accumulation of LH activity. يعني سواء كان HCG أو LH to bypass the threshold. So we measure HCG and we measure LH, and it doesn't pass the threshold with the 150 dose, neither in PCOS or others.
Rule of ovarian drilling.
هتضرب انا النهارده. انا هشوف الصبع طلع اهو مش هقدر اتكلم. طيب احنا بنعتذر عن الكلام عن الدريلينج لان ده ممكن يعمل مشاكل. الايفيدنس في الدريلينج ان هو as can be used as a second line. ده الجايد لاينز بتقول الكلام ده. انما from our practice خلينا نقول ان الجايد لاينز معموله في منطقه، انما احنا بنبراكتس في منطقه، وعلشان نمشي مع الجايد لاينز زي ما هي بتقول لازم تبقى احنا لينا our own guidelines. From my humble experience or from my professor's experience, all the time للأسف drilling in our country is doing harm more than benefit. If you are going to stick to the guidelines, okay, you can use it. But from the practice, it is doing more than harm than benefit. I myself, I have a paper about drilling that was published, and I've presented the paper in a couple of occasions in Egypt. And from the kind of questions that I receive after the discussion of this presentation, I stopped this presentation because after talking about AMH, and we used to measure AMH before and after drilling, and we talk about the very limited indication and the size of the ovary, and somebody came asking me in a conference, in a very good conference in Egypt, can we do drilling for unexplained infertility? After I heard this question, I stopped talking about drilling. In our practice, in our country, drilling is doing more harm than benefit, and I think this will close this discussion.
What will you do in a PCOS patient who don't respond to 200 international unit induction in non-exi cycle?
Okay. First of all, I should know what is this 200 international unit. If it is all FSH, I would shift to 50% FSH and 50% HMG, or even 1/3 FSH if it is very resistant and 2/3 HMG. This is in the cycle. But what after that? After that, if she is obese, I will try to encourage her to lose weight. I will try to correct her metabolic syndrome, lifestyle changes, pills maybe for 1 or 2 cycles, correct if they have very high LH, correct her hyperandrogenism, correct it before I redo. Okay? This is what we usually do. It is mentioned, and this will return to the previous question, that maybe these cases may benefit from drilling, but definitely I not put it the first or the second or the third. After correction of all these, if it is hopeless, I will have to do drilling to improve her response.
So, metformin, when to stop in pregnancy?
Some people stop it after just after the pregnancy test, and some continue it throughout the first trimester, and there are some reports that it decreases the miscarriage rate in these patients. So this is debatable.
Yeah. Can we use agonist triggering after induction of ovulation and non-exi cycle, taking
Definitely.
consideration of the impact on implantation?
Definitely we can use it, but from my practice, I didn't find a decent pregnancy rate in these cases. But it is reported, it makes sense, but from my practice, I didn't find a decent pregnancy rate in these cases. Maybe you can use it with intensive luteal support, I'm not sure, but I used to do it for maybe 1 or 2 years, then I used to give now even a minimal HCG doses in these cases. Dr. Hassan, can you comment on this question, please?
Exactly as you said.
Thank you.
Another question, myoinositol.
Myoinositol, it is present and it is used, and it was analyzed in the 2017 Cochrane, and it didn't give any benefit. It can be used, but it doesn't add any benefit to metformin. So why not use the cheaper and the most available drug, besides its other effects regarding weight loss and prevention of type 2 diabetes.
Does tegretol has a role in enhancement of vascular endometrial component in PCO?
Tegretol? I don't have any experience, or I myself, I didn't read about tegretol in this context.
This is the last question. Thanks a lot, Dr. Sherif Gaafar, for nice discussion. Thank you
very much. Thank you very much. Thank you.